Hi, my name is Simeon Nilasha, and for the trigger point of the week this week, we're going to be exploring the rotator cuff tendon or the rotator cuff muscles. So there are 4 rotator cuff muscles. We will come to those later. We're going to start by talking a little bit about shoulder pain in general. Now, shoulder pain actually is the second to third most common of all complaints that go to see the doctor. Generally speaking, about 1 in 3 people will suffer, 2 in 3 people will suffer shoulder pain at some point in their life. And shoulder pain can be quite debilitating. Some people rate it as high up as even sort of heart disease and cancer in terms of the impact on the life. And I've been specializing for 20 years in adhesive capsulitis, or frozen shoulder syndrome, which is very, very painful, often associated with night pain. So why do people get shoulder pain? Well, there are various reasons, but as we look at all the research, the main reason is aging. It seems like the shoulder was really designed to work efficiently, mechanically efficiently at least, to the age of 40, after which we tend to start seeing degenerative changes in the shoulder, and it can't adapt really as well as it went in the younger shoulder. So why? So we're living longer. They tend to sort of come after the age of 40. Also, there's a lack of metabolic activity, which is a kind of underloading of the tendon, and that's something that we're seeing more commonly in the modern world. An underloading, people sitting down on their phones, not using the shoulders, and then an overloading, kind of the weekend warriors decide to go out and sort of do boxing and stuff like that. So these are some of the reasons. Again, occupation. There's a great study which we're going to look at shortly, which showed that people that have been in the same job for more than 10 years, where there's overhead activity, painters, decorated, car mechanics, 100% of them will have a rotator cuff problem. And also sports and other lifestyle factors. For example, smoking inhibits collagen, type 1 collagen repair. So some of the other factors are this, that as the human has evolved from a 4-legged to a 2-legged animal, and as we stood upright, the scapula itself has become highly modified. So if we look here at the spine of the scapula, what we can see is that in the human being, the spine has become much more horizontal compared to the great apes, which are much more sort of vertical spines. So what that means is that the ball and socket joint in a human is relatively more compromised, especially when it comes to the subacromial space, that space under the arch of the acromion. So the human shoulder is really good up to 90 degrees, but beyond 90 degrees, there's a slight amount of compromise. So aging, occupation, anatomy. As we said before, this was a study published in 2004 that said that 100% of the population of car mechanics, house painters, people that have been using overhead activities in their job for more than 10 years will have a moderate to severe rotator cuff pathology. And again, another study done here shows that swimmers who don't go to the end of range when they swim are less likely to have a rotator cuff problem. In other words, swimmers that are constantly swimming at the end of their range are more likely to have shoulder cuff pathology. So quickly now, the cuff is a 5-layered structure interwoven with the bursa, interwoven with the coracohumeral ligament. So there's a lot of ligaments that run through it as well. There's 2 sides to it. We have the bursa side and the articular side. The articular is the joint side. And curiously, 2/3 of rotator cuff tears occur at the joint side as opposed to the articular side, or the bursa side rather, which is very interesting because traditionally people have thought that there was a kind of rubbing of the acromion that was sort of wearing away at the rotator cuff tendon, but it turns out it's absolutely not that. It's to do with something else, which we won't cover here, but I'll be happy to share with you another time. So when someone comes in with a rotator cuff problem, they come on a spectrum. There's a spectrum of problems with rotator cuff, so it depends on which part of this spectrum they're coming in. The normal tendon, asymptomatic overload, this is where there's obviously no symptoms, but it's still in pathology, or usually this one, reactive tendinopathy. So someone will come in with night pain, some shoulder weakness. Night pain is kind of pathognomonic, if you like, and a band of pain across the arm. And if you're not treating them and they're not getting better and they're not doing anything about it, you can get infiltration of the bursa, bursitis, tendon disrepair. Again, each of these stages can be improved with therapeutic intervention. However, once we get to a degenerative tendon anabursa issue, it becomes a lot more difficult to treat. So, in general, when someone's coming in with a rotator cuff tear, they're going to come in with weakness, band of pain around the deltoid, often sort of the drop arm test is positive. That's one of the big sort of signs, if you like, for a rotator cuff problem. And also, as people move the arm up and down in that kind of arc, they're trying to do adventitious movements, so they won't be able to sort of move it properly. But generally, it's pain and weakness. So I thought what we do now is we go into the Trigger Point 3D software and we'll explore the rotator cuff muscles together. So now we're going to look in the software and let's have a look at those trigger point maps for the rotator cuff. So let's start here and let's have a little look at the supraspinatus. So again, we've got all of these videos covered individually, these muscles in the Trigger Point of the Week software, but let's run through them quickly. Supraspinatus obviously it lives in the supraspinous fossa, inserts into the tubercle at the top of the humerus. And in terms of pain map, the supraspinatus pain tends to mimic trigger points, a sort of posterior shoulder, lateral deltoid pain. So that's very much the sort of pain map of supraspinatus. Now we know supraspinatus is the most likely candidate when it comes to the rotator cuff as one of the 4 cuff muscles. Oh yeah, we forgot to say those: supraspinatus, infraspinatus, subscapularis, and teres minor, as you all remember. So supraspinatus compromised because of the evolutionary changes. It runs horizontally, and then its moment arm is very much compromised in terms of sort of shoulder abduction. Generally speaking, it's relatively avascular towards the insertion, and there's a little area called the Codman zone, which is where we tend to get shoulder impingement pathology of subacromial pain syndrome as well. So there's there's the insertion attachment, but in terms of the belly itself, the trigger point can be a little bit more florid. So the pain map, look, for the belly of supraspinatus can come all the way down through the tricep, through the sort of dorsum of the hand, and into the back of the index finger. So that will be the map for supraspinatus. So let's look at infra now. Why not? Infraspinatus, more of a florid map. Generally speaking, with the trigger points of infra, they tend to be around the medial border of the scapula, sort of right at this area here. And again, we can see in terms of the pain map, we've even got sort of cervical, sort of mid-back radiations, but generally speaking, people tend to feel it here around the bicep, long head of bicep. It often mimics biceps tendinopathy, and all the way down to the palmar surface of the hand into the middle of the hand. You know, almost sort of like a burning pain. Some people even can confuse it with carpal tunnel syndrome. So supra, infra, let's go to subscapularis, fascinating muscle, often involved in rotator cuff pathologies anyway. As we know, sits in the subscapular fossa, inserts into the, again, the tubercle of the humerus. And the pain maps, as we've shown you here, can be anterior, but generally and interestingly, for subscap, pain can be at the back of the wrist, and sort of dorsum wrist pain is actually a really interesting finding for subscapularis, and we do see it. And again, also around the sort of inferior border of the scapula and sort of the posterior axillary fold in a little bit into the tricep. In fact, for that one, I think what we're going to do is I'm going to show you a nice warrior view there, because we can get a much nicer view of it like that. You see, we can get more fibers there. Perfect. So let's go back. So the last one is the teres minor. Now, teres minor, poor little thing, actually, you know, practically is part of the infraspinatus. I know some of you are going to disagree with that, but when you look at them together, they share a lot of the same fascia and they do kind of similar things. So anyway, in terms of identifying it though, trigger points tend to be just below the axilla, and the pain radiation map tends to be located more sort of around the tricep, posterior deltoid, back of the shoulder. So that's the teres minor. So they are the 4 pain maps for the rotator cuff. Hope you found that interesting. Please tune in again next week for the trigger point of the week. We're looking at some symptoms together. There's loads more videos on our Facebook and on our YouTube channel. Subscribe to us, like us, we like you, and we're really delighted to bring you more trigger point content. Thanks for watching.